I'm Paloma Rivero. I'm a second-year internal medicine resident from Eisenhower Medical Center, and I want to share with you a very interesting case I had recently in the hospital. I chose this case because I think it has a lot of teaching points, and I want to share with you some of the things I learned with this case. So the first thing I want to talk is about susceptibility profile of Candida glabrata, and I'm also going to talk about the tissue penetration of antifungal agents. So this was a 75-year-old male with past medical history of well-controlled diabetes, CKD3, paroxysmal AFib that presented to the ED complaining of right-sided facial swelling that had progressed over the past 5 days. The swelling started after he had 2 molar extractions. When the patient was evaluated in the ED, he was noted to be febrile. He had significant leukocytosis of 25,000, bandemia, and elevated procalcitonin. A CT without contrast was obtained, and it demonstrated some soft tissue edema, but there was no evidence of loculated collections. He was started empirically on ampicillin, sulbactam, and vancomycin, and OMFS was consulted. They evaluated the patient and decided to continue with the antibiotic therapy and hold off on IND. However, after the patient had been in the hospital for 2 days, there was no clinical improvement. The swelling hadn't improved at all, and the patient was actually getting a little bit altered. So there was the decision made to obtain repeat imaging, now with contrast. This imaging showed the soft tissue edema, but this time also showed some collections. One was superficial and deep from the platysma muscle, and there were also some subdural hypodense collections reported. At this time, we talked again with OMFS, and they decided to schedule him for an IND. We also talked to neurosurgery about these findings in the subdural area, and they were doubting whether this was an extension of the infection or if this was just an incidental finding, and they were just hygromas. So they decided no neurosurgery had to be scheduled. The patient had the IND, and the cultures came back positive a couple days later, growing Candida albicans and Candida glabrata. And very interestingly, the bone pathology report was consistent with osteomyelitis. Unfortunately, no bone sample was sent to micro, only to pathology. So we didn't have a bone culture, but we talked to our pathologists and they did PAS staining that demonstrated pseudohyphae consistent with a Candida infection. At this time, we knew that we had to start the patient on antifungal therapy. However, we were facing a dilemma. What was the best option for this patient? On one hand, we had a Candida glabrata infection, which in the US has reported 8 to 9% resistant to azoles. So choosing fluconazole would be a poor option for him because we would have a high possibility of resistance. As we know, echinocandins are the drug of choice for Candida glabrata infections while waiting for susceptibility results. However, echinocandins have minimal CNS penetration, so they weren't also a very good option for him because there was some concern of CNS involvement. So at this point, the best option for him would have been amphotericin B, but he had CKD3, and we knew that amphotericin was only gonna make worse his renal function. So at this time, we had to discuss with the infectious disease team, and we decided to do an unconventional combination of both fluconazole and micafungin to ensure adequate coverage and adequate penetration. Fortunately, a couple days later, the susceptibility results came back, and the Candida glabrata was sensitive to fluconazole. So the patient was continued on fluconazole with a plan to continue it for 6 to 12 months. We follow up with infectious disease, neurosurgery, and OFMS. I hope you enjoyed this case and you learned something, and thank you for listening.